And Fola, you can go ahead with the French. Okay. So acknowledging colonialism in the past and the present, we come together today from different places across Turtle Island as people who live on treaty lands and unceded territories. We work in a sector whose goal is to address social harms, and we must recognize that the production of these harms comes from the history of colonialism and its enduring practices, institutions, and ways of thinking. Colonialism is with us today, and we must commit to working in ways that reshape these institutions and practices to repair harms, to prevent future harms, and to work towards a more inclusive and just future. So just a few words about us. The National Safer Supply Community Practice is funded by Health Canada's Substance Use and Addiction Program, and our goal is to support the scale-up of safer supply programs through capacity building and knowledge exchange. We're a collaboration between three organizations: the London Inter-Community Health Centre, the Canadian Association of People Who Use Drugs, and the Alliance for Healthier Communities. We focus on the medical model of safer supply that's delivered from a harm reduction and public health approach, but we also support advocacy for non-medical models and decriminalization. We have lots of resources, including webinars like these. We develop tools and guidance. We hold community and stakeholder dialogues. We provide mentorship and support for prescribers and programs. We facilitate networking and community building, and we have give you access to lots of resources and literature. You can visit our website to access any and all of these things. Alex will probably drop a link in the chat momentarily for our website, and you're welcome to join us there too. If you're not already a member, you can hit the join button. So a couple of events that we have coming up. Our next monthly Research Spotlight webinar will be on February the 6th on the Imagine Safer Supply project in BC, featuring Erin Howley, who's a research associate with the Canadian Drug Policy Coalition. You can register for that on our website. It's at noon PST on February the 6th, and you can click the link that I'm sure Alex is going to drop in the chat to register for that one. Should be a really interesting webinar on that. Our next hot topic webinar is coming up on February the 23rd. And for that one, we've got Dylan from the Kootenay Insurrection for Safer Supply coming to talk about empowered choice and options for safer supply in rural and remote communities, which is a topic that we have a lot of requests for. So that should be also a great webinar. And you can register through our website or via the link in the chat. So we are recording this event and we will share it on our website. So be aware of that if you choose to participate in the chat. If you're having technical difficulties, we can't help you during the webinar. So we strongly suggest that you just log out and rejoin. That virtually always solves the problem. We have closed captioning available in English, but we also today have live interpretation into French. So if you choose to access that, just click the globe at the bottom of your screen there and choose that says interpretation underneath it, and you can choose to listen in French. I should probably try and say this in French so that anyone listening can do that, but I think I'll spare you my effort. So if you want interpretation, again, it's the globe at the bottom of the screen and choose interpretation. We will have a certificate of attendance that we'll put a link to in the chat about halfway through the webinar. If you want a certificate for any reason whatsoever, you can just follow that link, give it your name and your email address, and it will automatically email you the certificate. And I think that's it for me. So I'm going to stop sharing. And I'm going to introduce Corey Ranger. Based in Coetson and Malahat First Nation territory, so-called Cobble Hill, BC, Corey, who uses he, him pronouns, is a registered nurse and a project lead for the Safer Knowledge Translation and Exchange project. Corey is also the president of the Harm Reduction Nurses Association and a public health resource nurse for the BC CDC. So I will send it over to you now, Corey. Thank you.
Good morning, good afternoon. Really excited to hear, to see how many people have joined today. That's really wonderful. And also just great work to the National Safe Supply Community Practice, because those next two webinars of Imagine Safer Supply and the one with Dylan sound like they're going to be wonderful. I'm going to share my screen and hopefully not incur too many technical difficulties as I usually do. And just start off briefly here. Can you see my screen? Thumbs up.
Yes, we can see your screen.
Wonderful. Okay, so I'm going to start off just with a little brief disclaimer. We talk about perspectives on fentanyl safe supply, but we here at the Knowledge Translation and Exchange team are not here to sell prescribed safe supply. You'll learn this quickly, that we are here to discuss our experiences and the experiences of prescribed safe supply operators. And our role is really to try to make these programs work as best as they can, and for them to be as flexible and grounded in harm reduction as possible. However, we acknowledge that there is a significant amount of limitations and barriers, and that's part of what we want to be able to talk about today as well. Before I get any further, I want to acknowledge that the Safer Knowledge Translation and Exchange team does work with individuals and organizations across all of Turtle Island and honor the life force of Indigenous people who have had their land stolen and who continue to resist ongoing genocide. Addressing the root causes of the toxic drug supply is deeply connected to decolonization. I also want to acknowledge that the content we are discussing today is made possible by people with lived and living experience of drug use, sharing their knowledge and experience and expertise. They've been the ones who have borne the greatest risk in innovating during this toxic drug crisis. And without their generosity, vital life-saving harm reduction initiatives simply would not exist. In terms of an introduction, what we're going to talk about today, and I'll preface this by saying you won't be hearing the most from me today because I'm here to moderate and facilitate and introduce some wonderful individuals who are going to be doing the bulk of the talking. I'm going to give us the quick lowdown of the Knowledge Translation and Exchange project, a little bit of an update, some perspectives that we've heard from operators, and then do a panel introduction and go into the questions. We have some stock questions for everybody to kind of get started out of the gate, but we really encourage audience questions. We want to hear from you. This is specifically about implementing and running fentanyl prescribed safe supply programs. And the people that you're here to talk to today all have extensive experience in that. The Safer Knowledge Translation and Exchange program is a federally funded initiative through Health Canada's SUOP program. It's intended to do capacity building, but really hands-on capacity building, going to sites, helping people write their protocols and their policies, training staff, resource development. We also do some collaboration on research and evaluation, and specifically looking at what are the barriers and facilitators to prescribe safe supply. How can these be scaled up, and what are some of the areas that requires further investment so that we can eliminate barriers to access. Before the pandemic, actual implementation of safe supply was largely theoretical. Concept documents like the Safe Supply Concept Document had outlined priority considerations, but we still didn't have a good idea of how it would look. And at the onset of the pandemic, we started to see that shift in the drug supply. We also saw the emergence of BC's risk mitigation guidance prescribing, and we encountered many problems trying to navigate that document as we started to learn some of the barriers associated with prescribed safer supply programs. We at ABI then received funding to develop, implement, and evaluate a flexible model for prescribed safer supply. And after a year of operation and of consultation with people who use drugs and doing the work exclusively via outreach with things like tablet hydromorphone, we learned quickly that we were not meeting the needs of people who are accessing our program simply because the drugs were not the right drugs, and they weren't in the right doses, and they weren't in the right formulations. And so we opened a clinic where we were able to start offering 3 different fentanyl-based prescribed safe supply options: the fentanyl patch, the tablet dissolvable Fentora pill, and injectable or sublingual sufentanil. And so that clinic is still in operation, and we've since, through the KTE project, been able to start supporting other projects to implement fentanyl prescribed safe supply. What have we been up to? We're currently working with 6 SUOP-funded programs and a couple of others just in a more casual basis. I'd say that we're still, friends on Facebook, not in a relationship at this point in time. but we do capacity building. We write their policies or review their policies or support them in determining what type of equipment their sites need, or going and doing training with their staff. And we also do a ton of feedback and evaluation, both initially through a needs assessment. We talk to program operators about what they perceive to be the biggest barriers to running their programs. And then when we complete trainings, or when we conclude our relationship with a partnered organization, we get feedback from them as well. And we try to collect all of the different perceived and actual barriers, what people think is going to be a problem, what actually ends up being a problem. And we try to collect all of that information so that we can potentially offer some recommendations moving forward. I'll share a little bit about some of the perspectives that we've already heard. And so here's just a sneak peek of what we heard from some prescribed safe supply operators regarding barriers to implementation. Like I said, we're always going to try to be brutally honest at KPE, and part of our work is to support implementation to make this work, but also to document, record, and report what's not working and where the gaps are, and how do we raise these concerns to decision makers. And so perspectives of operators regarding barriers, someone said addiction medicine and subsequent prescriber hesitancy. Another individual said building capacity for physicians is truly to truly embrace a flexible model for safe supply. We've encountered a lot of underlying beliefs about safe supply that are rooted in abstinence-based thinking and medical models. Another person said timelines. It feels as if we can't move fast enough. The overarching pressure of the toxic drug supply crisis and working to scale up an under-resourced community has been challenging. Also, the funding structure, have the pressure to get the results, have high intake numbers, success stories, and reportable targets is a weight that never leaves the shoulders of everyone on the team. On top of that, the looming end date and no commitment of continued funding. And one other person said, I feel like our hearts are in the right place and we want to go in the right direction. But if we want to have a truly successful safe supply program, we need to have more options for folks and increase accessibility to a regulated supply of drugs. We need to actually center people who use drugs, trust what they say, and express their needs, and empower them to guide their own care. And those are some of the barriers that people have. Preliminarily, this program's only been running for the last 4 months, but those have been some of them that have been highlighted. And then just a little quick lessons learned from our end. There is an ongoing recurrent theme of problematic nature of precarious funding models and pilot studies. We know that there's concerns with incrementalism and half measures, and knowing that this program needs to go further, these programs need to go further. I've forgotten a note that I need to slow my speech, which means I have had too much coffee. We know that there's significant tension points between addiction medicine and harm reduction. We know that a lot of these programs end up having some capacity issues. We're currently running into issues related to benzodiazepines and non-benzo sedative contamination in the unregulated drug supply, both in individuals potentially going through withdrawal if we meet their needs through a prescribed fentanyl safe supply, and also just not being able to match their needs for what they're accessing from the unregulated supply. We also know that there has been recurrent issues with metrics for success and the need for a robust body of evidence, which is still lacking. What we've learned from trying to support program operators in developing their initiatives is that every program ends up looking different, even when they're using the same protocols. And that's because oftentimes it depends on the setting, the community, what resources are available, what staffing models are being utilized, what the hours of operation are, the history and relationships of that organization in the community. And there's a significant knowledge gap in what we want to do and what we think we should be able to do and what ends up coming to fruition. We've also learned that supply chain management is a bigger issue than we acknowledged out of the gate, and supporting organizations to prevent supply chain disruptions, or to have contingency management in the contingency management in the event of a shortage has been one of the bigger issues that we've had to support. And then, of course, the next thing that we're looking at with these programs is how do we actually scale them up? How do we help support them getting out of programmatic settings and out of small kind of pilot study settings so that there's more wide scale accessibility? that's just a bit of a snapshot of what the KPE project is, where we've been, who we're working with, and what we're working with, and some of the lessons that we've learned to date. And now I'm going to move on to introducing our wonderful panelists. So first is Laura Cartwright. Laura is Safer KTE's lead consultant and based out of the Lekwungen and Wasanich territory, colonially known as Victoria, BC. Laura Cartwright is an experiential frontline worker. She has provided services for folks in the downtown east side of Vancouver, Surrey, and Victoria, BC for the last 12 years. For the past 2 years, Laura has worked at the Victoria Safer Initiative, supporting access to prescribed safer supply. Most recently, Laura adds her voice to the knowledge translation and exchange team, while continuing to work with people who are using substances and who experience homelessness. Next is Dr. Ahmad Gahari. He's the owner and founder of Community Apothecary, a progressive outreach pharmacy specializing in mental health and addictions. Dr. Gahari and his team have helped pioneer safe supply and opioid agonist treatments in Vancouver and Victoria. After over a decade of practice, Dr. Gahari is as determined as ever to eliminate overdose death in Canada and beyond. Next, we have Dr. Kelsey Roden. Kelsey graduated medical school in 2017 from UBC Northern Medical Program. She went on to family medicine residency in Victoria, finishing that in 2019. Immediately following residency, she entered the BCCSU Addiction Medicine Fellowship Program with completion in June 2020. Currently works for Kool-Aid Community Health Center, providing integrated primary care and addiction medicine care. She also worked on the addiction medicine consult service for the Victoria General and Royal Jubilee Hospitals. She joined AVI Safer in the fall of 2020 and currently works there providing safe supply with pharmaceutical fentanyl alternatives. She also provides consultative services to VIHA and AVI. And last but not least, Tim Gauthier is a family nurse practitioner in Vancouver, BC. Tim holds a full-time clinical position as a prescriber of safer alternatives within a supervised consumption setting, with a focus on prescribing fentanyl-based products to program participants. Tim holds a leadership position with the BC Centre on Substance Use as the Director of Nurse Practitioner Addictions Fellowship. In addition to being a former alumni of this program, Tim was also a founding member of the Harm Reduction Nurses Association and was vice president for a 3-year term. Tim is very excited to be here, and so is everybody else. I'm going to stop sharing now, and we'll move on to the panel discussion. Tim, Laura, Kelsey, Ahmad, everybody ready? All right, so I'm going to get us started off, and everybody else who's on the line, make sure that you feel free to put some questions into the chat or into the question tab. But I'm going to start right out of the gate with something more general for each panelist to answer. What is one thing that you've learned about prescribed safer supply that others may not know? And I'm going to start off by deferring to Laura.
I best unmute then. Well, again, what is something I've learned about prescribed safer supply that others may not know is that it is a long way from being rolled out, as it were. Safe supply is limited, the expansion is painfully slow, and we're pretty limited to a few prescribers and programmatic sites. And another thing is that we're hard pressed to compete with the illicit polluted drug supply. With the introduction of benzos and xylazine, we can barely match the need. That said, I think that people make an informed decision when accessing safe supply, knowing that it won't meet the impact that street supply has, and yet they are still seeking to make a positive change in their lives and have a reprieve from the criminalization that goes along with drug use. So for me, it debunks the myth that it is just catering to an addict's indulgence. Rather, it is seeking to provide positive change for folks.
Awesome. Thanks, Laura.
Okay.
Over to you, Kelsey.
Thanks, Corey. I would say it's hard. Well, the first thing I would say is it's hard to know what other people don't know, but something I've found interesting through this whole process, especially since we opened up the Safer Clinic and started providing a few different options of fentanyl products, is that offering different options has provided me a great opportunity to engage pretty meaningfully with my patients and my clients about safer supply, about their goals. So rather than just here's my OAT option menu that I can offer you, and they all kind of do the same thing, with a few different options with safer supply, I've been able to have conversations about like what someone's withdrawal looks like and what their triggers might be and how we might manage that more safely than using the unregulated supply with the different medications that I can offer. So it's been pretty cool. I think I found folks have started to open up a little bit more about that kind of stuff when they know that there might be an actual way to meet it.
How about you, Ahmad?
Yeah, I think I've learned that navigating the ever-changing landscape is challenging, and it requires a change management approach with staff. So I think it's important that people are involved in these projects to kind of keep everybody updated and give the reasons behind the changes, so they're a part of the process. Also, I view safer supply not as a catch-all solution for opioid use disorder, but it's a key component of an overall strategy. And I kind of see it as a pathway to a safe place that's much lower risk of overdose. So one analogy I use, hopefully it's appropriate, is that, we want people to kind of climb to the mountaintop and give them their mountain gear and whatnot so they can reach the mountaintop. But I think sometimes with the illicit market being so dangerous, sometimes I think people are maybe in quicksand and they're sort of sinking. So we can't really, mountain gear is not going to help them. I think we need to get them some rope, which I kind of view as safer supply. Let's get them onto solid ground, a safe place, and then we can start giving them the tools to start sort of climbing the mountain. So that's how I see it, and that's what I've learned.
Awesome. Thank you so much, Ahmad. And last but not least, Tim, what is one thing you've learned about prescribed safer supply that others may not know?
Yeah, I think the thing that surprised me the most when I joined my program, which I know I'm supposed to give a broader overview of my program later, but I guess just a little bit of foreshadowing is that my program is a PRN program where we prescribe lower doses of safe supply products to allow for greater flexibility in accessing our program and staying attached to our program. So with that, when I started our program, I was worried that our doses were just already at the gate, just too low to really be any benefit to the people who were accessing our program. But I was surprised at how many people that attached to our program were actually benefiting from the smaller doses we were giving in a PRN context, and how they were staying engaged with our program. And they were actually feeling the doses we were giving, and that they were saying it was giving them the benefit, which we also saw just play out over time. So, yeah.
All right. For our next question, and I'll just acknowledge there's a comment in the chat about use of the term addict, and I would reiterate that and apologize that we will henceforth be using person who uses substances or person who uses drugs. And thank you for the feedback in there. I'm going to move on to. Oh, go on.
Also want to clarify that was the perception, and that is not what our perception is. That is a general public perception.
So we're going to move on to talking about now what is working with prescribed safer supply, and I'll start with Kelsey this time. What do you feel like is working with relation to being offered prescribed fentanyl safe supply?
Yeah, similar, or I guess expanding on the last question, I'm finding that prescribed safer supply is giving me a different way of improving rapport with clients, giving them a different way and sometimes a more effective way to communicate what their needs might be to me as a prescriber. And through all that, I'm finding that, especially compared to more traditional treatment programs, is providing clients with better autonomy to manage their own substance-related goals, which I'm finding is really cool. And once in a while, I am finding that we're starting to match people's tolerance, which is also super fun.
And how about you, Tim? What is working right now with prescribed safer supply?
I think the variety of options that are becoming available to people, I know overall it's still limited to certain programs for the most part, but I think just a willingness to engage new and novel products like powdered fentanyl is a good option. Like I don't prescribe that yet, but that's something that's on the horizon. People are trying to match street use with street a very street similar product, and I think that's amazing that we're moving in a direction like that.
And changing gears a little bit now, so we'll talk a bit about limitations. And I'll pass this over to Laura. Laura, what have you noted so far about the limitations of a prescribed safer supply?
There's the things that are apparent to people who use drugs, in that the safe supply is not smokable and most often does not provide a euphoric effect or a rush. But the things that bother me personally the most, and that I see people struggling with, is that they can't necessarily access where they're at. People who are homeless are often left out or pushed out or lost to contact. People who need their substance use to be private can't access discreetly. Folks with mental health issues can't maintain access without support, and folks with mobility issues continue to suffer. I believe safe supply needs to be a no-holds response to a chronic emergency, not a boutique program that only caters to a lucky few.
Thank you. Very well said. And Ahmed, how about you from the pharmacy perspective? What have you noticed in terms of limitations of prescribed safer supply?
Yeah, I think it was mentioned already, but the commercially available products are not ideal to minimize the medication burden. So patients are having to inject too many mils, so upwards of 5 milliliters, which is very high. The dose is not strong enough for everyone and can't meet everyone's tolerance. Also requiring people to put on multiple patches, as many as 10 patches, and having to rotate that just makes it more challenging and burdensome. Also, just overall funding and space limitations. There's not enough space available for all those in need. And everybody's spoken about the accessibility around the province, which we need. And as well, just the fact that it is new modalities that are being developed. So we need more experience and evidence to help support these initiatives.
Great. I'm going to interject with a couple of audience questions, and then we'll get back to some of the more stock questions. But there's a few here that have started to accumulate that I think it would be really great to answer right out of the gate. And so I'm going to throw this one first to Healthy. And the question is from Alyssa Stryker. I don't know much about the nitty-gritty details of the fentanyl product mentioned. Could someone give a quick overview of the options and why each one might be appropriate for a particular person? What factors are at play when deciding on the right fit?
Sure. Yeah, that's a good question. So Corey had briefly mentioned that we provide, apart from like dilaudid tablets, and we also provide oxycodone tablets at Safer. But as far as fentanyl products go at Safer, we provide fentanyl patches, which essentially function much like OAT. So depending on who you ask, some people would consider it OAT and some would consider it Safer supply. So either way, it's, someone who maybe can't get into clinic every single day. It allows better flexibility because they only have to come in 3 times a week to get their patch changes. Folks who do want something to be sort of a backbone to help them manage, for example, keep them out of withdrawal, that kind of stuff, it can be a really good option. Another option is Fentora tablets. So it's sublingual fentanyl that just dissolves, of course, under the tongue. I guess they're effervescent tablets. So those ones, we provide them, it's meant to be twice daily dosing. So we provide them up to twice a day, and patients will come in and they can get both doses if they can make it in twice in the day. Because it's fentanyl, it generally will provide a little bit better opioid equivalency to illicit options that are out there. And it's longer acting. So again, it's especially folks will find if they can take it like very much towards the end of the clinic day, then it might last further into the night. to help stave off withdrawal overnight. And then they just have a few hours to get through until the clinic is open again, rather than suffering all night long. And then the last option that is a bit safer specific is the sufentanil. And we offer that one either sublingually or through IV injection. I think most of the folks are using it through an IV route. And so they'll come into our site. They can take a dose up to 4 times a day, every hour. So there has to be an hour in between for safety purposes. But folks will come in and be given like a small syringe from our nurses, and then they can use that at our OPS style booths that are set up. And then some people will actually wait in clinic for several hours and get several doses in the day. Some just come in and get 1 dose if they're just feeling the need for 1 that day. So there's a lot more flexibility in that regard. We've actually had a few folks who do really well by coming in and using a sufentanil dose first thing, and then getting, say, their OAT or their patches applied or whatever. And so they get something to manage that sort of morning withdrawal, and then the other long-acting versions kick in. So there's kind of a small menu of options. Hopefully that answers your question.
No, that's great. Thank you so much. And I'll ask Tim, who doesn't work at Safer Victoria, to also share a little bit about the options that are provided at his place of work.
Yeah, same pharmacotherapy, except my program doesn't offer the oxycodone. I think you mentioned that as part of your program offerings. We don't offer that currently, but our dosing strategies are different. So for our Fentora tablets, we dose 4 times a day. They're smaller doses, but they can have them up to 4 times a day. And then our sufentanil, they can have it up to 6 times a day. Yeah, a limit to the sufentanil, which I think Ahmed mentioned, was that the volume of fluid is 5 mils. And if sufentanil misses, like if it leaks into the tissue or it's not injected into the vein, it can burn quite a bit. And some people find that very, very uncomfortable. Others don't mind it as much. Because another redirection that people can do if they can't get it into the vein is they can put it in the muscle. But again, with the burning, some people find that intolerable. Others don't really mind it if it's once in a while.
Great. Awesome. I'm going to now bring the next question here. I'm going to direct over to Laura, and might not know the percentage, but the question essentially is, what percentage of clients are not able to make it in twice a day? And what are some of the practical reasons why people aren't able to make it in?
I can't speak to the percentage, that's true. But I mean, the reasons people can't make it in are myriad. As I mentioned, people are homeless, they're in camps, they have to deal with all those unpredictable factors of being homeless: bylaw, violence, harassment, and inclement weather as well. People are often suffering from unfathomable, unimaginable pain, exacerbated by them having to trudge on over to a clinic maybe a few times a day. And sometimes that's impossible. And made more so, obviously, by those factors I just mentioned, but we don't necessarily have the most accessible sites available, and some people are pushed further and further away from that access. And I mentioned that people have sometimes have mental health issues and need support to remember to show up and or to deal with sometimes maybe something that's not compatible for them in the atmosphere of the sites. We aren't able to provide the comprehensive level of support we need for the folks dealing with substance use. I would love to see outreach be just the norm so that people could be met where they were at and not have to make it into a site. I could go on, but I think that's good enough.
Awesome. Okay, I'm going to take a pause from the audience questions and go back to one of our questions for the whole crew. So the term flexible models is utilized a lot. Many prescribed safe supply programs that we work in or work with are referred to as a flexible program. We have a whole category from Health Canada for prescribed safe supply called flexible models. What does that term mean to you? And is a prescribed safe supply program flexible? Are we being flexible? I'll start with Ahmad on this one.
Yeah, I think a flexible model in our context as healthcare professionals is one that works within our respective scopes of practice and legislation to make the most accessible care possible. So this includes trying to reduce the time from presentation to actually accessing safe supply. And also, once they start, maintaining the continuity of care to ensure prescriptions are up to date so that they don't go without when they need it. And having a plan in place to adjust the dose up or down so we can achieve the target dose is also something that we need to be flexible as well with. I'm realizing that 6 people per day die in BC from drug overdose. The model we have right now isn't working. So we need to work hard, be flexible overall in our mindset, and find the model that greatly reduces and eliminates, hopefully, drug overdose. And so part of that is being willing to be flexible and change the protocols or procedures, or even the drug products you're working with, and actively seeking out feedback from participants to find what works. So I think kind of the overall approach in the day-to-day, I think we are flexible as we can be within those scopes, but hopefully working with different levels of government and whatnot, we can find ways to make it even more flexible.
Terrific answer. How about you, Tim? Flexible models. Are we flexible?
I think we're certainly trying, I think every program is trying their best to be as flexible as they can with the constraints and limits that they have on their program. But having said that, I think one of a major limit is the hours of operation for a lot of the programs. They're quite similar, like often they're 8 to 4, 10 to 6, some, daytime business hours, but that's, those aren't the hours that people are limited to using substances, right? Like we use substances throughout the day. And while we contain safer supply products within witness ingestion or observed models of care, then I think there needs to be a bit of a push for us to expand the way that we're actually offering those services, even in a very practical sense, like hours of operation.
And how about you, Kelsey?
I'm glad you asked me, because as Tim was talking, I was like, oh, I wanted to add something here, so I was going to interrupt anyway. I think flexibility, there's two perspectives from what I'm thinking. One is from the patient-centered perspective of recognizing that the way that we as medical health professionals view medications might not be realistic for a person, might not meet their needs. And a great example of that is what we've already talked about, where Fentanyl is technically twice daily dosing, but over what Tim is doing, they do 4 times a day dosing because that matches what their clients need better. That's a way to be flexible. And then flexibility from sort of like a, I guess, prescriber perspective is meeting regularly to adjust protocols and match what people are telling us. So hearing on the ground what's happening, what's working, what's not working, and then adjusting, not just sticking with because that's what we've always done.
Thanks, Kelsey. And last but not least, Laura, on flexibility.
Not very flexible myself these days, no sir. Well, again, we should be catering to the context of people's lives. And what Tim said earlier about, adjusting hours is, we mentioned people use at all times of the day, but and we also know that our clients are very nocturnal. Some of our population are very nocturnal, and due to stigma, criminalization, harassment, the way our society is set up, that people are pushed into the night, into the alleys, and into the darkness to use, and we don't offer safe supply at night. And so people are reaching to illicit supply and overdosing. So it would be wonderful to have a flexible model that would include, say, something like Insight, where people could just go and get their prescriptions at all those hours. We really need to look at a 24-hour service, or at least a 20-hour service, because I don't, just as a hospital emergency room is open, I think safe supply should be, again, a response to a chronic emergency, not, it's not, it's not this neat thing that we're doing. It was meant to be a response to a crisis. And we really need to keep that in perspective while we mull things over. It's just, I can't say enough, it's an emergency, right? And I think we're still punitive in our response. You know, we react with titration, we react with cutting people off, we react with the obsession with diversion, perpetuates the perception of the user as a criminal. And this is just not the case. This is the status quo on substances. This is every man, every person. Thank you.
Thanks, Laura. I'm going to pivot back to some audience questions, and just I'll let folks know that if you're asking for specific like doses, or if you want to see the protocols, those are available on request if you just email the Safer KT or the Safer Victoria project. So if you're looking for like really specifics about like dosing protocols or stuff like that, you could just reach out and we can share our protocols with you, or we can share the protocols with you. And I'm going to ask this question here. I'm going to start with Tim. What can and needs to be done to get more prescribers on board, and also to support prescribers who are already on board? Who should and must be involved in this support?
Yeah, I think meaningful knowledge sharing, like in real-time knowledge sharing, would be really helpful. Just because as prescribers, like we always need to be guided by evidence, and right now we don't have the same level of evidence that we have for other therapies. But what we do have is, I know in terms of hierarchy of evidence, it's low quality, but we have anecdotal evidence, or we have program, evidence or quality improvement evidence or support that way. So I think if we could have a meaningful way to share information with each other that wasn't so siloed or wasn't so specialist, or so, didn't have this air of like a niche knowledge or a niche, like a niche specialty, then I think we'd have more uptake, and bringing in therapies that are more, like maybe even more familiar, like oxycodone, or like prescription ready therapies like Fentanyl, things that are available if we had the knowledge, and if we could understand, what was happening in a practice setting, or what's happening like with our prescribing group, then I think it would be easier for us to implement those therapies in our own practices.
Thanks, Tim. And how about you, Kelsey? What can be done more to support, encourage, grow practice among prescribers?
Yeah, I mean, very much what Tim said. I think that knowledge translation. So an example of that could be creating provincial protocols that are not specific to funding streams or certain clinics, that are generalizable the way that we have OAT guidelines, right? So I guess from that perspective, I think it's creating a normalized approach to safer supply prescriptions that is just, this is the therapy. So it's less of this debate or less of this uncomfortable newfangled thing, and more of a normalized process. I know a lot of prescribers, as Laura mentioned, the concern is around diversion, and that's what keeps a lot of people from prescribing. So things like setting up funding for clinics to be open longer, to be more flexible in that way, I think would actually improve prescriber uptake if they had it. It's not as flexible as in it's not providing, for example, like tablet carry doses, but it could be a way for prescribers to be more comfortable doing something like a fentanyl patch or a Fentanyl prescription if there were realistic hours for somebody to be able to access what they need when they need it in a semi-regulated fashion. That could potentially be a way to increase uptake.
Great. This is going swimmingly, and I've been given a prompt by the folks organizing on the other end that there's going to be a link that's going to get dropped into the chat for evaluation of today's panel. And so I've been asked to announce the Zoom poll and survey, and they'll put out the links. And then now I'll go back, and while I gather myself, I'll give a quick, easy question over to Tim. Tracy wants to know if anyone ever takes their sufentanil sublingual at Insight.
No, I'm not aware of anybody ever taking it that way. It's either been IV or IM in my practice setting.
I don't know why I was expecting that to be a longer answer.
Sorry about that.
I'm gonna give Ahmad a question. We've spoken a little bit about the importance before about integrating pharmacy as a member of the prescribed safe supply team. Can you tell me a little bit about the role of pharmacists, mainly what might some of the misunderstandings be, or the ways that we can better utilize the role of pharmacist in prescribed safe supply programs?
Yeah, I think like the key role for the pharmacist is to make sure the medication is being dispensed is as prescribed and safe per the protocols being used. Another key role is communicating with the nurse and prescriber to ensure everyone's up to date on any missed doses, or if any dose changes are needed, or if there's any key points that need to be communicated to the patient. And also overarching, Corey, you mentioned it earlier, just making sure you have the drug, right? So with the pharmacy, inventory management and communicating with wholesalers and drug manufacturers to ensure there's adequate stock is very important. And as well, if you see a drug shortage coming down the pipeline, like contact the project people, and so we can maybe manage the participant numbers and weather the storm, so to speak, until the drug shortage is passed. So I go to my wholesaler and tell them, okay, this is our expected usage for the month. Or I even go to the generic drug company that's making it, or the brand drug company, and I give them a heads up as well. Because like, for example, when we started using sufentanil in Victoria, I was told that we were doing, my pharmacy there at the time was doing more sufentanil than the rest of Canada combined. So their budgeting for these different products like fentanyl patch is maybe more relevant to, cancer pain or palliative care usage. They weren't anticipating it being used in this manner. So if we just start ramping up usage, then it's kind of inevitable that it's going to be a shortage. So I think that's an overarching thing that pharmacists can maybe help with in their own practice, make sure that you have the drug. There's other roles. In terms of the misunderstandings, I'm not totally sure what those are, but I'd happy to speak to any that folks might have.
That's a great answer. Thank you. I'm going to quickly go through a string of questions at the top here. Laura spoke a little bit about not comparing with the unregulated drug supply, but I'm wondering if SAFER have any protocols for prescribing both pharmaceutical fentanyl and medical benzodiazepines. Kelsey, do you want to answer that?
Yeah, we do not have a protocol. Generally, we're not at this point co-prescribing benzodiazepines and opioids, although it's a hot topic. And so I wouldn't be surprised if at some point in the near-ish future that becomes a protocol, but at this point we're not, which I think is definitely a problem for a lot of our program users for sure.
And William, what specific doses are you using to stabilize people? The protocols vary. The maximum dose for sufentanil is 250 micrograms. That's SAFER is 250 micrograms up to 4 times a day with 1 hour between doses. Current max dose for Fentanyl at the highest dose protocol is it 3,600 micrograms BID, Kelsey?
It's 3,200, although case by case, I think we have someone up to like 6,000, but the general is 3,200 BID.
And then from Ria, what have we learned about overall opioid consumption is affecting in clients using that SAFER? SAFER Victoria puts out their stats pretty publicly, and most recently, 75% of respondents reported decreased accessing of the unregulated drug supply, and that information is also available. You can follow them on Twitter, Vic SAFER. project, and I actually will put out quarterly updates on feedback from participants. Is there any consideration for bowel care for clients using high-dose opioids? Yes, in every one of the programs, there's also an accompanying bowel care protocol, which we make sure that we're offering to people and we're assessing, because we do know that there's a significant risk for constipation and other potential GI issues that people could have when they're receiving high-dose opioids. And so we want to be able to be proactive about addressing those needs. Okay, I'm going to give this to, let's see, I'm going to give this to Kelsey. What advice would you give to a program working towards starting a fentanyl patch safe supply program in a clinic that has occasional closures on Mondays and Fridays due to stat holidays, where medical staff may occasionally be unavailable for patch changes?
Yeah, I mean, I think these kinds of clinics are actually where fentanyl patches are ideal, because they're 3 times a week rather than having to be available for 7 days a week. So it definitely takes a little bit of, well, a lot of communication and contingency planning for when folks do show up or try to show up on, say, a stat holiday. Lots of communication with your patients. But I will say, so outside of Safer Victoria at Kool-Aid, where I also work, we did start setting up a patch program through our pharmacy, which is closed on stats and weekends. And so we just had really clear communication with our clients before and as they were getting started on the program about, like, you need to show up on these days. If you show up on a weekend, no one will be there, that kind of stuff. And it went well for some people. It didn't go as well for others, which I really think just highlights the need to be flexible. And part of that flexibility is offering hours that are realistic for folks. But with the right client, you definitely can, with really clear communication, you can open up programs that just have the 3 times a week on specific days, and folks will be able to work. We had also set up a partnership with a different pharmacy so that on stat holidays, like for example, a stat Monday, the patients would go to a different pharmacy on those days so that they still get their dose on the Monday rather than having to go an extra period of time without. So I guess the answer is great option. It just takes a bit of creativity to manage those days and clear communication.
Great. I've seen a lot of love for pharmacy related questions. So Ahmad, I'm going to give you 2 more if that's okay.
Yeah.
Do you ever have any issues with wholesalers when ordering meds?
Yeah, like I think communicating with them about what you're doing and why you're doing it, and trying to provide supporting documentation, be it BCCSU guidelines or news articles, because it is new. And I think some of them, the drug companies in general, are a bit hesitant about this area because of the opioid lawsuits that have occurred in the last several years. And yeah, it did trigger a Health Canada, investigation in terms of our narcotic amounts. But as for any pharmacy, it's incredibly important you keep detailed records of your narcotic counts and have everything really solid in that way, so that you're prepared if those situations do arise, because Health Canada will, or even the college will look at your pharmacy if you're doing things that are maybe out of the norm. So again, it's just communication with the different parties and trying to provide supporting articles or documentation as much as possible.
Wonderful. And a follow-up question related to pharmacy is there a way to influence pharmaceutical companies to make products the way that they're needed, e.g. 250 microgram patches, more potent fentanyl powder? If so, do you know where the request or pressure needs to come from? Should it be coming from government direction, or would individual pharmacies be able to influence the products that are made?
Yeah, unfortunately, I don't know the answer to this. I don't have a great strategy. Otherwise, the products would have been made by now. I think maybe everyone, when I speak with generic drug sales reps and they say, hey, maybe you can carry our molecule. I'm like, okay, well, get me the fentanyl patch, even 500 per hour, and then I'll go with you, or 1,000 even. Or I tell them, we're probably this fentanyl, 50 microgram per mil, even though we might be ordering some now, it might go away if a better product comes along because it doesn't meet the need. So I try to tell them, and when they give me an opportunity to speak to somebody at the head office, I try to advocate as much as I can in my own role. I definitely think that it carries more weight if it's coming from the government, because often they think this is just a niche area and it's not really going to have a mass market appeal. So for example, with the fentanyl patch, I try to say, well, there's some palliative patients, they might require more than 100 microgram per hour. So if you had a higher strength patch, that could actually be beneficial for that population. So it's not just this niche area that you think it is. And so trying to find different angles to, good or bad, appeal to their sort of money-making aspects as well. And then I think having the government also advocate is important, because the BC government was suing drug manufacturers for the OxyContin situation. So then if people might be afraid sort of the government. So if it's coming from the government, then maybe that would allay some of their concerns. So yeah, I try to, use my voice wherever I can. And it maybe if all pharmacies kind of get in that and they realize, oh, it's not just Ahmad in Vancouver talking about this, there's people across the country are, so maybe that'll help, but we're still working on that part.
Awesome. Thank you. I'm seeing that we're coming up on time, and I'm seeing also that we want to make sure that we do respond and acknowledge to the comments in here. So I'm going to try and answer some in real time, and then we'll close out with a couple of final questions if folks still have time. I don't know, Alex or Fola, how you usually manage that, if it's a hard cutoff or if we have an opportunity to carry over the time limit.
We've got another 30 minutes. You're good.
Oh, wonderful.
You asked for 90 minutes, so we said, okay, go ahead. So you can continue.
I did. Hey, well, I'm going to put an hour in my calendar, but I guess we're here. Kurt, we have to acknowledge we have knowledge about heroin. We're manufacturing it in Canada, and still more people prefer it to fentanyl. People will adjust their tolerance to it if there's a regular supply. Also being dispensed at Crosstown. We should be talking about this, as well as pressuring governments to expand this availability. We couldn't agree more. Safer Victoria has been part of that group that has been trying to apply pressure, and we hear from participants as well that fentanyl isn't always the option that they're looking for, and so we agree. Today's panel is specifically about prescribed fentanyl safe supply, but we would acknowledge and agree with what you're saying. Tracy Day, government has approached the drug companies to produce a stronger patch and increasing concentrations on patches. They have not been cooperative for a variety of reasons. Government is still the best conduit, though. What, if any, challenges with regulatory bodies for prescribers? Johnny is asking. I don't think there has been any, but I'll pass it over to Tim. Do you want to answer that one?
Yeah, I'm unaware of any pushback, at least for nurses and nurse practitioners who are engaged in safe supply programs or safe supply prescribing. Nurse practitioners in BC and nurses, we have a position statement by our college saying that they do support nurses and nurse practitioners to engage in prescribing safe alternatives to the poison drug supply, as long as we're doing so in consideration of current available evidence and guidelines put out by the BCCSU. So as long as we're referencing those documents or those platforms, then we should be good. I think program restrictions or program limits are probably one of the things where are just limits, because these therapies and products are new. Programs, as far as I know, are moving forward with protocols that are quite they're set purposely, so it doesn't give a lot of wiggle room to make just on the spot changes to what you want to do, because it needs to just go through collaboration and consideration with the team, which just adds a little bit of a time gap or a time delay in things that you want to do with people as you move forward.
Okay, great. There's a few questions here about take-home doses or witness dosing. So do doses in your experience need to be witnessed? I keep hearing of the bottleneck in the medical model is the setting clinical staff or any staff observing the ingestion as a condition of compliance. As well, does from Tracy or from Lynn Pollock using Tracy's login, does flexible also include increasing at-home doses versus doses requiring pickup at your clinic or pharmacy? And so the reality is there, across all prescribed safe supply programs, take-home doses or witness doses not needing witness consumption has been a problematic barrier for folks. And maybe I'll start off by letting Laura, do you want to speak to some of the barriers that people experience or some of the issues with having to require witnessed ingestion?
I can try. Obviously, there is some stigma attached to the witness injection or witnessed use. People feel that they should be able to be, and rightfully so, be independent in their administration of their substances. It is difficult to accept somebody suddenly interfering in your private affairs. The process of using drugs is a very interpersonal experience, and it is always difficult and hard not to feel a bit invaded by witnessed use. And so I think that it requires a lot of clear communication as to why, and that the team is working toward providing that autonomy. But in the meantime, we have to play ball with governments and policymakers. It isn't ideal. People should be able to take home their doses whenever possible, and we should be trying to move toward that so that people can carry on with their lives. This, as I said, is not just this is not medical treatment. This is a response to a crisis. So the witness dose has a treatment vibe to it. And what we want is for people to be able to use their drugs whenever and wherever they need to, and that it would be adjusted to the life that they're I don't know what's happening, the life they're trying to live. And definitely coming in for witness dose interferes sometimes drastically with that. I don't know if I answered that question.
I think you did so wonderfully. And all these little floating heart emojis, I have to assume, and little clappy hands are a response to what you're saying. I'm going to pass it over to Kelsey now for a perspective from prescribers on the same question.
Yeah, I think that expanding witness doses really needs to be a part, or at least a discussion going forward with every protocol that's being made at every clinic, right? And I couldn't agree with Laura more that keeping things as witness doses really does keep things highly medicalized, which is a huge barrier for a lot of program users. I will say from the prescriber perspective, like witness dosing makes us feel much more comfortable, right? Because of the whole diversion. What if this gets into the wrong hands, blah, blah, blah. Diversion is extremely stigmatized. Witness dosing or requiring people to witness is extremely stigmatized. And I think that for any program to be successful, there needs to be room and flexibility for discussing clients who might be really good candidates for witnessing. And some people just end up doing so much better once they're able to take that dose home with them and use it as they see fit, because then it's actually meeting what their needs are. And so having the flexibility within your teams in the programs that you're developing means having the flexibility to discuss when a witness might be appropriate or when a non-witnessed take-home dose might be appropriate. At SAFER, we do have criteria for when someone reaches different eligibility points when they might be a good candidate for taking home, for example, their Fentanyl dose. And there's been a couple situations where someone had a take-home carry and then things maybe really destabilized to a point that felt a bit unsafe, and so that was put back to witnessing. But we also have clients who were seemingly very chaotic, let's say, or maybe not necessarily quote unquote stable enough, and then they got a witness dose and things have really stabilized. So I think it goes both ways and really just requires rapport with the clients to be able to have those conversations, communication with the team, monitoring to see how things are going, and flexibility to consider the fact that keeping things highly medicalized doesn't work for a lot of folks.
Fantastic. Oh, we are making our way through these questions and comments. Keep them coming, folks, if you have them. Colin said one of the things we heard in a recent study of people on safe supply or wanting to be was that consideration wasn't given to what people were using before getting on the supply and being started on lower doses that meet their needs. And so who hasn't gone in a while? Tim, we'll start with you and then we'll pass over to Laura about the experience of matching people's needs, matching people's preferred drugs, and in the route of consumption, where we're missing so far.
So this is a bit of a tricky one for me to answer, only because the nature of my program is a PRN program, so our doses are fixed at a lower dose than other programs are able to accommodate. Yeah, because other programs that are operating on a maintenance model, they have better capacity to titrate doses and then retitrate doses if there's a missed dose protocol or some such. Whereas our program set up more for prolonged absence from the program being, expected or assume that will happen, and we don't need to make adjustments so early on. So I have a ceiling limit of what I'm allowed to prescribe as part of our program, which I was very hesitant and worried about when I started participating in prescribing within this program. But then what I found is that, even lower doses for some people are able to meet, some need, or we're able to have some substantial improvement in the quality of their life based on their self-reports with the lower doses we're giving. And, more frequent access is usually how we try and mitigate that aspect. And then we're pretty quick to rotate through therapies. Like, if somebody's, on fentanyl, but, they're just, it's not hitting right, or they don't really like it, we'll try Fentora and try to be very responsive, so we'll try that for a couple of days. If it doesn't work, we can go right back to the fentanyl, or we can, go to hydromorphone liquid or hydromorphone tablets. We just kind of rotate through the different options that we have available, and, hopefully we'll find something that's a good match. And our program, we don't discharge somebody from our program like officially. So if somebody leaves our program even for months or says they don't want to participate in our program for now, we still keep them as part of our priority list. So if that changes or we get new products that come on board, they're welcome to return. So we don't have a discharge, a firm discharge for anyone who's entered our program.
And over to you, Laura, same question.
I'm not sure how to answer that. I think that again, people using street supply are often find that they cannot get away from it. Long-term older users will remember the functionality afforded by traditional heroin, and younger users aren't even aware of, the soothing effect the heroin offered versus fentanyl, and also the ability to function that heroin offered versus fentanyl. We have a hard time keeping up with people get into the habit and the need to use so frequently with the street supply that the overwhelming anxiety of that threatens them even before they're physically ill is something that we don't often talk about. So the frequency, the dose, and the in-between is often not really looked at. People might try to titrate up to meet the need, the prescriber is titrating up to meet the need, but when we have a participant who is used to accessing drugs, often, especially smokable products, it doesn't address that even though the person may not physically need that drug that frequently, the psychological effect is that they do, and we can't fill in the gaps. Having the reluctance around diversion means that people don't necessarily have substances to fill in that space and assuage that anxiety, which is quite crippling in nature. So yeah, help me wrap that up, Corey, because I'm a little lost.
I think you did a great job answering that question, and we're, as I said, coming up to the last three here. There's a couple of questions about diversion, and I'll just point out that, Russell, to your question, is there research on diversion? There's actually a link that was put in the chat by Robin that is called Reframing Diversion. Where is it? Reframing Diversion for Healthcare Providers Frequently Asked Questions. And so I would direct you to that. This question is for everyone, and we'll start with Ahmad and then go to Tim. Given how much different programs vary, what do you think is the best way to scale up safer supply to increase accessibility while still maintaining a flexible model?
I think, yeah, getting more practitioners and nurses and pharmacists on board. And, I think pharmacy is we call ourselves the most accessible healthcare professional. So naturally, my thought is, let's get pharmacies dispensing these medications more often. And, there's a pharmacy on just about every block, and there's a pharmacy in every small town and city in the province. So I think sort of developing these protocols further and sharing them, and some of the work that we're doing through KTE to make it more available around the province is the way to go. But also I think part of that is maybe addressing some of the stigma that might be inherent in certain professions as well. And not everybody wants to work in this area, and kind of educating folks on how rewarding it can be and how much of a difference we can make, including in the pharmacy world, I think can hopefully increase the uptake of these initiatives. And so pharmacy, let's step up.
And Tim, scaling up and improving flexibility.
Yeah, so like the program I work for isn't a standalone safer supply program. It was brought into an already existing supervised consumption site, which I think is something that can happen in other ones across the province and the country as well. We don't have a lot of staff structure that was added to our program specifically for the safer supply program. So they brought in me as a prescriber. I have an addiction specialist kind of overseeing the program, and then I work closely with the pharmacy, and then we have a nurse who dispenses the medications, and then we have a program worker who kind of does the flow. So in-house we have a staff of 3 people that were added, which I think is a pretty reasonable staff infrastructure to bring into other sites as well, as long as they have the background support. If we were to stick with a witness model, I think it's scalable to add into existing OPS and supervised consumption sites.
Awesome. And how about you, Kelsey? Improving flexibility and accessibility.
Yeah, I would just echo what Tim said, first of all, about integrating these kinds of programs into places like consumption sites and OPSs. It sounds like, to me, a genius idea. I think in a lot of ways, it really comes back to, again, kind of normalizing these protocols. And the term Laura used, which I liked, was, I think, boutique programs. It needs to stop being these boutique programs and just be something that is an option that people do. And realistically, for more prescribers, generally speaking, to be on board, it probably needs to be within witnessed protocols. So, witnessed options, but empowering prescribers to be able to follow very distinct protocols and a provincial level so that they feel safe and they feel like they're given permission to do this kind of prescribing, I think would be a way to sort of normalize it and make it just another part of addiction medicine care.
Great. And over to you, Laura. Last words on this question. improving
Well-
flexibility and accessibility?
I mean, again, looking at the context of people's lives, I like the idea of it being normalized in pharmacies and OPSs, but also I would like to continue pushing for outreach teams of, nurse practitioner, nurse, and lived experience workers going out into community and delivering medications to people who don't have the mobility or the ability to leave their belongings, to leave their tents, to leave their carts behind. We need to be catering to those people. We need to work out a way to serve survival sex workers and provide them with safe supply. Can you imagine the reduction in violence they would experience? So as many as there are people and situations, and again, to address people who want a discreet service, who don't want to come to an OPS, who don't want to go into a pharmacy that may be prescribing oat as well. They want that discretionary. Could they not perhaps have their substance delivered? So, I mean, what we need is to destigmatize people, decriminalize people, and realize that people have myriad reasons that they become addicted. And so the response should be as varied. And again, I'm going to say, this is a crisis, it's an emergency. While I enjoy this panel and associating with all these amazing people and we're all on the same page, like I feel like every hour that we're not dispensing medication, we're losing someone. So the lack of capacity is quite conspicuous and lends itself to all kinds of speculation about why, and the answers are not very comforting, right? So let's respond as we did with the naloxone to the opioid crisis. Let's respond as we did to OAT. Like it is an emergency. I can't say it enough.
Well, this has been wonderful, and we've got one last question, and this is I intentionally saved this one to the last because everyone can get their final words in. From William, how do you respond and deal with pushback on this program by those who say it enables people? I'm going to give it to Laura to start with this one, or she said no. I can pass it over to somebody else.
It's okay. Enables people to what? That's what I got to ask, right? Like, what are you saying we're enabling people to do to access a safe supply? I mean, the name says it all. Should we restrict access to safe supply and instead push people back out the door to access a fatal supply? Should, people are concerned that children will somehow stumble across prescribed safe supply. Would you rather that they picked up a lethal dose of fentanyl? I'm sorry, but people are losing their family members, they're losing their friends and loved ones. I don't, enabling someone to make a better decision, enabling someone to stick around another day, and then maybe, like as I did, choose to put down substances, and it's just actually quite a disturbing question to me, not to the person who posed it, but that people still throw that out, that we're enabling people, and it defies logic to me.
I knew you were the right one to start with. Ahmad, it's a tough one to follow. Closing thoughts. What would you say to someone who's asking that question?
Yeah, very tough. I don't have much to add to that. That hit the nail on the head. I think it just comes back to seeing people for being people and trusting them and listening to them and listening to their experience and what they need to get well or survive, and trying to meet those needs. I don't think these programs are making using opioids all of a sudden incredibly appealing to folks. I think it's just, as I said in the beginning, I think it's a lifeline. If somebody's sinking in quicksand and we give them a rope and try to pull them out, we don't tell them, yeah, that's not enabling them. We're just trying to literally just save their life in that moment and give them another option, so they don't have to go to that illicit supply that is risky. Another analogy I use is if 0.01% of people who drink beer this weekend drop dead and die, what would we do? We would probably recall that brand or that lot, and there'd be something done. But in this case, since it's in the illicit market, there's no other option for folks. People can choose not to drink that specific beer or drink something else, but it's just about giving people another option. So it's not about enabling. I think it's about giving them a chance to stay alive and live another day so that they can continue sort of climbing up that mountain.
Wonderful. Kelsey?
Yeah, I mean, I think we all know that the comments around enabling are really founded in the war on drugs and prohibition and those kinds of mindsets. And all we need to do is look at all the evidence that things like managed alcohol programs, for example, are not enabling unsafe drinking. In fact, they reduce unsafe drinking practices, and needle distribution didn't enable worse, substance use or dangerous substance use. It actually reduced it. So it's the same concepts that providing alternatives that meaningfully replace the toxic drug market actually reduce safety concern or reduce unsafe issues and make things better. We have hordes of evidence to support the idea that these kinds of programs are not enabling. And I think it's important to find politically correct ways to call someone out on those mindsets, because those mindsets are founded in poor logic and morality-based thinking, which is just untrue.
Oh my goodness, I can't believe we're almost done. This has been so great, and all of your answers have been wonderful. Tim, you get the final say on the final question.
Yeah, this is obviously a tough one to follow with such, like a brilliant platform that I'm kind of launching myself off of. So, yeah, I think the thing that I always feel when someone says we're enabling drug use, we're enabling like the consequence of the overdose crisis is I find it kind of jarring, because like the opposite of that is that we do nothing. We already know that doing nothing isn't working, right? Like what's happening now is, it is a true crisis. It's devastating, right? And I think any of us who are working in this capacity, and especially for those who are living this day in, day out, like it's like a dreadful time to be alive in this context, right? And then by doing nothing, like we're like enabling this destruction to just continue to ravage our communities and destroy lives and end lives. So safe supply is an attempt at enabling survival and respect and dignity and self-determination, right? So I think that's what we're trying to enable with this. And, we're doing it in the most responsible way that we can with the evidence that we have. We're working together to try and make this a better situation. So, yeah.
Wow. Well, I can't thank you all enough for spending the time to talk about this today, and for all of the work that you do, and for all of your wonderful words. I learned from this as well. And I'm just going to share my screen here for one last moment here. Hopefully you can see the slide. So just to close, do you want support with your prescribed safe supply program? Well, give us a shout, saferkte@gmail.com. We're happy to connect with you, do some needs assessment, find out how we can be of best support, and also just sharing resources however best we can. I want to thank you all again for joining us today, and I will stop sharing and pass it back over to, will be full, I assume.
Oh, I'll take it. Thank you. I'd like to thank Corey, our facilitator, and all our wonderful panelists. Thank you so much for coming today and sharing such great information. I'd also like to thank all of our attendees and our participants for coming and for bringing such interesting questions for the panel to answer. And I'd really like to thank our wonderful translators, our interpreters, who have been working, speaking very, very quickly to try and keep up with everybody. So with that, I think I will stop recording, and everyone can get on with their day. If the panel would like to stick around for a debrief, please do. And thank you to everyone else. We will have the recording on our website. Usually it takes us a day or two to get it up there just because of all the processing that's involved. But the recording and any major resources that were mentioned will be on our website quite shortly. So you'll be able to share it with anyone who wasn't able to be here today. So thanks again. And with that, we'll draw the webinar to a close.